Hello, everyone, and welcome to this Orthopedic Trauma Association virtual industry session. It's been sponsored by CurvaFix. We very much appreciate their support, and we thank the OTA for giving us the opportunity to engage with you, our audience tonight, to talk about some advancements in pelvic ring and acetabular fixation with a unique implant. And so we're going to jump right in. We have some brief presentations. We really would like you to use the Q&A to ask questions of the group. We'll try and answer some of those real time as the presentations are going through. And we'll also do a discussion at the end. So we have some challenging questions we're going to ask our panelists about this technology and how they employ it. My name is Samir Mehta. I'm Chief of the Orthopedic Trauma Service at the University of Pennsylvania. And I'll be talking about the antegrade posterior column screw, a percutaneous technique. And so I'll go over a little bit of what we have done historically and what I'm doing now in my practice. So I'm going to show you this patient. He's a 29-year-old male. He's status post a motor vehicle collision. You can see his height, his weight, and his BMI. So this is a big man, no other way to describe it. He has a acetabular fracture on the right. He has a left sacroiliac joint disruption. He is history of schizophrenia, and he works as a construction. He works in construction. He's a very nice man, but compliance will not be his friend. He will be, and he's made it clear to me, and his mother, who's involved in his care, has also made it clear that it's going to be very hard to keep him off his feet and keep him from working, which he must do for a variety of social and personal and professional reasons. So just remember him as we go through this deck. Just very briefly, I want to touch on something that's not pelvic fractures, but geriatric hip fractures. I think we all agree that when we see a fracture like this, the answer is fairly straightforward, right? We look at this and we say, we're going to fix this. And our goal is to get that patient to the operating room as quickly as possible. And this is sometimes our attitude towards our colleagues or towards some of the necessary paperwork to get the patient to the operating room. But we know the data is pretty clear that with geriatric hip fractures, getting them up and moving, and getting them fixed in a reasonable amount of time is really important. The reality is that as pelvic fracture volume increases year in, year out, both and mostly over the age of 60, we're not seeing that same impact on pelvic fractures, right? We're seeing that despite the number of pelvic fractures being fairly high, only a very small percentage of pelvic fractures are being treated operatively, particularly in the frail patient population. And so that's just something to consider as we think about some of the talks we're going to hear a little bit later, and just thinking about our approach and our philosophy around pelvic fractures and why we look at those differently than, say, a geriatric femoral neck. So I'm going to talk about the fixation pathway for a posterior column screw, very specific. You can talk about going antegrade into the posterior column, and this Sawbones model shows where that antegrade screw would go in. This is not a percutaneous procedure when done antegrade, right? You have to make an incision, if you do it traditionally, about 3 to 4 centimeters over the medius pillar. You have to dissect down the inner table. Sometimes you get into bleeding there as you elevate the muscle off the inner table. And you have to identify your starting point for that posterior column screw, antegrade. That is an open procedure. So this is not a percutaneous procedure, and it's very doable if you want to do it in an open fashion, obviously with the morbidity of opening. The obturator outlet view will confirm where you're heading. You can see the blue dots that are present there. And you target your screw towards the center of those blue dots. The C-arm comes in from the uninjured side. And again, the starting point for an antegrade posterior column screw is on the inner table, posterior to the acetabulum. And in really large patients, this can be sometimes very challenging to do because their pannus, their body habitus, prevents the ability to get that screw in that correct trajectory unless they're doing a truly significantly open procedure. The iliac oblique is the other view that we get with this imaging to go antegrade. And again, the goal is to be medial to the acetabulum. The more traditional way, probably most of us put posterior column screws in, is percutaneously, and this is a percutaneous technique, and this is done retrograde. It goes from the ischial tuberosity up the inner table of the ilium. In this case, the setup is really critical. There's two different ways to do this. One is to do it supine. And if you really hate yourself, you could do it supine. This is where one person has to hold a leg up with the hip flex while the other person does the actual insertion of the screw. In this case, the ischial tuberosity must be prepped into the field, and you have to really bump the patient up so that you can drop your hand and be able to place your screw in the correct trajectory up that ischial tuberosity. So again, if you really hate yourself, you can have somebody kind of hold the leg up or put it in a harness or something like that. I truly don't like doing it this way. I think if you have an unstable situation, it can displace the fracture as you move the acetabulum around. You can also do this prone, and this can be limited by the other injuries that they have and where you have to position your implant, body habitus, that sort of thing. But it is easier to do in the prone position if you're going to go percutaneously up the posterior column retrograde. In this case, the starting point's on the ischial tuberosity, and you have to make sure that you protect or are medial so that the sciatic nerve is protected. And you have your obturator outlet view, which will confirm that you're staying, and you stay within those blue dots you see on the screen to make sure that you're putting in a safe screw. The iliac oblique view, make sure that your screw is outside the joint. I like to use a drill tip here because as you go past the acetabulum, you want to make sure that you are on the inner table of the ilium and not going too far in. And sometimes it's very easy to overpenetrate that and have your screw sticking into the iliopsoas muscle. And this works well for a low posterior column fracture. So I'm going to share a patient with you. She's a 77-year-old female who's had a pathologic acetabular fracture. She was treated conservatively initially, but had significant challenges mobilizing and had increasing pain in her acetabulum. The acetabulum was relatively non-displaced, but still she had, like I said, significant trouble mobilizing. We discussed converting her to a total hip arthroplasty or some kind of hip arthroplasty due to the pathology in the acetabulum, but she's not healthy, and really, for a palliative perspective, it made sense to do something more percutaneous. I had already placed an anterior column screw in her, so that's that CurvaFix that you see there is down the anterior column. And now I'm going to put a screw in the posterior column. You say, well, why don't you just go prone? There were some issues with ventilation and concerns about her being able to lay on her stomach to go prone. And you could argue you could go supine and just lift the hip up. But in her case, she had a very limited amount of soft tissue over her ischial tuberosity. And so I elected to proceed in an antegrade fashion. And so in this case, I got my obturator oblique and my iliac oblique. Sometimes with the with the obturator oblique, you do need to roll over a little bit to be able to see the inner and outer tables as you place this posterior column screw. I like to localize with just a simple Kirschner wire to make sure that I'm in the right trajectory. And once I'm there, I tap my wire into place and I make a small incision. I then use the drill guide and a wire to position a entry wire into the in between the inner and outer tables, and then use an opening reamer. Where's my opening reamer go? I use an opening reamer to open ream the proximal aspect of my incision. The opening reamer is here's the wire and here's the opening reamer. So you can see the opening reamer there over here on the right hand side picture, and there's plenty of room to be able to place that opening reamer between the inner and outer tables. Once the opening reamer is in place, then I can use a ball tip guide wire that's steerable, and I use that to gain access to my my posterior column. So you'll see here the ball tip guide wire is in. It's steerable. It's directed. It's got a sharp trocar point to it, so I can direct it in whichever direction I want to go. And so here you can see the ball tip guide wire now passing down into the posterior column. You can see this on my obturator outlet view, as well as my iliac obturator oblique view, as well as my iliac oblique view there. You can see here in this case, the ball tip guide wire is heading towards the acetabulum. I can then manipulate and rotate it so that it goes down the posterior column. You can see the fracture on this image on the left, and you can see that ball tip guide wire crossing the fracture line and then wrapping around the acetabulum so it stays safe. This is very similar to doing an intramedullary nail. You want to guide your ball tip guide wire down the canal, if you will, and then I seat it in the ischial tuberosity. And so you can see here my ball tip guide wire is now seated. In this case, then I'll ream with my reamer down my posterior column, following the curvilinear path from that percutaneous truly percutaneous incision over the gluteus medius pillar there. Once I ream, I then can measure, obviously. I switch out my ball tip guide wire for a smooth guide wire. So for those of you who are used to doing, and I shows you how old I am, I still remember when we had to switch out from the ball tip guide wire to a smooth guide wire before putting down an intermedullary nail. So the concept's the same. There's an exchange tube. You exchange the ball tip guide wire for a smooth wire, and then I can place my cannulated CurvaFix screw down the posterior column. Antegrade, percutaneous. And so here's what the final product looks like. This is an AP view intraoperatively. I typically get postoperative CTs to confirm the trajectory of my screws and to make sure that my reduction is appropriate and my screws are safe. And so that's what the final product looks like, all done percutaneously through a couple of small incisions. Did not have to place this prone. I did not have to hold the leg over my shoulder or have the resident potentially hold the leg over his or her shoulder to place a retrograde screw. So getting back to my gentleman here, the 29-year-old male, status post motor vehicle collision, big man, BMI of 46. I'll show you a picture of his physique in a second. But he had this left SI joint disruption and he had a right acetabular fracture. Here's a couple of choice CT cuts. I was very concerned about him ambulating on this pelvis and acetabulum. The mother, like I said, made it clear that he was going to weight bear. Despite her ability to try and take care of him, he made it perfectly clear that he was going to go back to work almost immediately after he left the hospital. He had no other injuries. This was isolated, and he was otherwise stable. And so for him, I did a percutaneous SI screw on the left, and I did percutaneous anterior and posterior column fixation. And you'll see him, this is his 5-month video in clinic a couple of weeks ago. He has no pain. He actually returned to work about 2 or 3 weeks after surgery. I recently just discharged him from clinic. And so you can see him doing squats there in my office. So he's done quite well. Obviously, my posterior column screw there should have been longer. I basically didn't pre-op plan well and should have requested longer screws for the posterior column there. But I had my ball tip guide wire all the way down. I just didn't have a screw long enough to go down this gentleman's posterior column given his massive size. And so that's a function of preoperative planning. But otherwise, he did well. No infection, no hardware failure, despite immediate. I'm trying to play this video again. Immediate. Sorry, I can't play that video. But immediate weight bearing on this. Thank you. And so you can see that he has no pain and is doing quite well. So with that, I'm going to turn the program over to Dr. Wetzel, and Dr. Wetzel will present his experience with CurvaFix. Thank you.
All right, thanks, Samir. I'm just going to check and see if I have control. Not yet. So I'm going to talk about some trickier fractures that required percutaneous fixation that I think the CurvaFix implant really was a benefit and can highlight in this particular type of patterns. Since I'm using the CurvaFix, I've really noticed some ease in terms of switching over to CurvaFix from traditional intramedullary fixation for the pelvis. And I think this highlights some of that in some definitely curved intraosseous pathways. And I think there are multiple benefits to the way CurvaFix works, one of which I think is simply just ease of insertion when it comes to a curved intraosseous pelvic pathway. And the other we'll talk about throughout all of our presentations is the advantage of the increased stability that you get with a bent axle type construct. So I'll present 2 cases. This is the first case, and we'll talk about multiple different pathways. And at the end, please keep some questions in mind if you have any concerns about overlapping pathways or how to navigate that or how to think of maybe even a new pathway we haven't tried, but I'll show you some interesting ones. This is a 76-year-old male newly diagnosed with prostate cancer, had a very low speed MVA, like grocery store parking lot type MVC, and presented pretty in pretty bad shape. He was banged up pretty bad. The airbags deployed. He was having a lot of internal bleeding and had some hollow viscous injuries. And he ended up with me after this initial scout image like this. So he got taken for an X-lap. And at our place, trauma X-laps never really get closed. So this patient came out of the OR packed with an Abathera wound vac on his open abdomen, and then he became more stable, but he wasn't really ready to be closed yet from an abdominal standpoint. After he came out of the OR with general surgery, we were able to finally get some good advanced images, and it shows that he has this LC2 variant where he's got a typical crescent fracture of his posterior right-sided iliac crest, and he has essentially bilateral anterior columns, a very essentially proximal floating symphysis type injury, where rather than we have really rami fractures, you have pretty high root of the rami type fractures with associated inferior ramus. And you have this obviously iliac crest with a little comminuted segment. So tackling this is a little challenging. And it also, you can see through on his upper right image there on the 3D that he has this sort of really complete anterior column component that comes down through the joint. So tackling this for me in the past was I need to work through an open abdomen. Maybe I'd like to smiley face plate this and make it fully stable from supraacetabular corridor all the way around to the contralateral supraacetabular corridor. And then also taking care of that iliac crest can be quite challenging getting that posterior for plating. And if you look at his two-dimensional cross-sectional imaging, I wasn't really wonderfully happy with his right-sided SI joint. I mean, if you look side to side, I think if I were to look at his right side in and of itself, I would have said, yeah, it's probably pretty normal. But if you look at it compared to his left side, it's definitely gapped. So I was a little worried about a subtle SI joint injury too, or at least an impaction type injury to the right-sided sacral ala, giving the actual joint some instability. So in this particular case, I just wanted to highlight some of the uses for CurvaFix and also that every corridor doesn't necessarily need to have curve fixation. In this particular case, I was able to stabilize first that SI joint with just a partially threaded compression screw in the S1 segment. And then just to stabilize, and if I thought I could catch a piece with this particular pattern of the fractured segment at the S2, it was a very close injury. I think I just got maybe a piece of it, but just to stabilize the joint a little bit even further. And then he clearly had the crescent injury, so he had standard LC2 type fixation. Now, in the case, and you can look at the guide wire image on the left, he did not have a straight shot corridor for an intramedullary screw. And anterior column fixation percutaneous, at least for me, has always been a bit of a challenge because the corridor to me is really very worried, obviously, superior penetration of the pubic ramus once you get past the joint and running into iliac vasculature, especially if you don't get a good obturator outlet view and see that true dip in the ramus. You can be out of the bone and having screw threads right up against the iliac vasculature and not even really know it unless you get the right view. So for me, a curved implant, or at least the ability of the implant to take a curved interosseous corridor, is really beneficial in that you can ride within the bone and not have to worry about things I used to do in the past, like bending guide wires to put screws through curved corridors, but then still the implant being straight, and having to work that bent guide wire out of a straight screw. And even in some really osteoporotic bone in particular, I've had bent guide wires pull the entire screw out of the bone. So this is really where it's been advantageous for me, at least early on in my practice, or early on in my usage of this in my practice. And if you look, this is the starting point for a retrograde CurvaFix, retrograde ramus screw, which I don't do often. Typically, I think this implant does really well for antegrade fixation, and I think it can be a little bulky if not deployed correctly right around the symphysis. But the way this lined up for this particular patient, I think it was best for fixation, the way his incisions worked out, and really navigating around that LC2 screw. I think I was able to get the implant, at least my plan was to get the implant past the fracture and maybe around the LC2 screw, or maybe stop short. But to come out at antegrade, I think that would have been a little bit of a tricky angle. So you can see that the start point for a retrograde CurvaFix, I try to keep as posterior or internal or medial into the pelvis as possible so it doesn't cut out the front. And these are some of the pictures of what it looks like driving the wire across this corridor. And I think this really shows, especially in the central and the right image, how not straight that corridor is and how a curved implant can be beneficial in the sense that using that ball-tipped, curved, paddle-tipped wire, you can really use that ball, especially around subchondral bone and cortical bone, to deflect away from structures at risk and stay intraosseous within the cancellous bone. It's actually really easy to do when you have really healthy, strong bone. This person wasn't that old, 76. I think the blastic metastasis of his prostate cancer probably helped bulk this up in terms of its density a little bit. But this stays in bone very nicely. And I think one of the early tips and tricks of getting this implant to work well for you is that as you're changing your trajectory and spinning the wire to change the angle, you're tapping along as you're doing that so that the vibrations of the wire help spin and rotate within the bone. And you don't just get this coiling effect where the tip is fixed and you're trying to spin and turn and you get a twist and coil on the wire, which can, if you keep coiling and coiling, of course, it will end up breaking. So just a gentle tap as you're spinning, and you can see going from the far left image to the central image where you have essentially a 180-degree turn in that wire, you're able to navigate that corridor. And looking at the far right image on the inlet, you can see that the corridor is also not straight in multiple planes. So this is what it looks like as the retrograde CurvaFix goes in. And you remember he also had a contralateral injury. And because of the way the CurvaFix sits, I was not able to start a retrograde contralateral implant, but rather an antegrade implant as well for the left side. So being able to utilize both retrograde and antegrade corridors in the anterior column is really advantageous, and it flows really nicely in terms of how it fills the column. And what I mean by that is if you think about a 7.3 mm screw or a 6.5 mm screw or a smaller even 3.5 screw, you can cannulate the corridor, but are you filling it up and getting that intrinsic internal fixation that you would also get, for instance, with an intramedullary nail when you get isthmic fixation? And I think with this implant, you definitely can add that to the fixation repertoire of this implant when you can fill the corridor up. It also helps with reduction and it makes it quite stable. You also see that with that anterior column screw for the left side of the pelvis that's going antegrade, you can get quite distal and medial into the pubic body. And ideally, you can actually curve and come down and come a little inferior down the pubic body to really make a bend in the implant and gain additional stability. So this is what some other views look like. Now, the previous pictures for this case were while the patient's abdomen was still open. So I didn't want to do any open fixation while his abdomen was open. So knowing that I can get these tough corridors as well with a curved implant was very nice. And in this particular case, I think you can see how the retrograde implant overlaps with that antegrade LC2 screw. Or rather retrograde LC2 screw. And then also once his belly was closed and he was stable, this was on a second day back to the OR, I was able to plate his iliac crest just to augment fixation. So these are his images at 6 months. He's a little further out at this point, but you can see the ability to really capture a very curved corridor. Both of those implants are not straight, and you can imagine potentially having a significant issue getting a straight screw through those corridors. The other thing that this really benefits from is the stability that's intrinsic to what I've previously stated, and I've talked to some other people from CurvaFix about, is the bent axle phenomenon, where you have a bent, rigid rod within a bone. And if anyone has ever treated a femoral nail that's been placed in the past that didn't break from a subsequent trauma but bent, you can understand how painful that is to remove that nail. And I've done that a few times, and it is a long day at the office when you cannot get that nail out because of its bent, rigid structure. That's essentially what you're intending to impart in terms of the bone and stability with this implant. So that additional stability lends me to be a little more aggressive with weight bearing as well. Now, for this particular person with a right-sided SI joint and pretty comminuted crescent type injury, I protected him on the right, but I was able to let him go full weight bearing on the left. And even with protection, I was letting him do stand pivot transfers for the first 6 weeks and then letting him weight bear after that. So just some examples of antegrade and retrograde anterior column fixation. So we're going to think a little bit out of the box on this one. This looks like a pretty benign injury. In fact, it's even hard to kind of pick out the injury on this x-ray. This is a 74-year-old who's probably physiologically 94. Her bone is quite thin. It's very fragile, and this is just a ground level fall. And I'm frankly surprised she didn't just have a run-of-the-mill hip fracture with how this looked. You really can't tell where the injury is when you look at this, but she was having a very difficult time mobilizing. She was unable to stand. She had some back pain. You can see her spine fusion there, but really she was relating this to a new pain from the fall, not able to mobilize with physical therapy. Now, on cross-sectional imaging, you can see on both sagittal and coronal plane imaging, she has essentially a crescent variant that really fractured and impacted right through the superior gluteal, superior side, the greater sciatic notch, greater sciatic notch. And if you look at three-dimensional imaging, you can see that impacted injury through the iliac wing out to the iliac crest. It doesn't complete, actually, because her bone is so pliable and fragile, but it looks very buckled and displaced at the sciatic notch. Also, subtly, there is an anterior column injury to the pubic root on the right as well as the inferior ramus, which is a little more obvious to see. So for this particular case, I want them to be able to get out of bed. I want them to be under better pain control so they can mobilize. And I'm alluding to what Samir was talking about initially is I want to make sure that this patient can be treated like a hip fracture. They can get up and go. They don't have to be in bed. And this person was not that. So essentially, I first tackled this by doing what I thought was the easiest plane first to tackle, which was the anterior column screw in an antegrade fashion. Again, using that guide wire to drive through and make those turns and bounce off the intact cortex and bury itself all the way to and almost into the pubic symphysis. And I think we'll see or potentially see a little bit later some actual symphyseal fixation as well. But for the anterior column in this particular case, first started with that antegrade CurvaFix. And then this is just to demonstrate how you can overlap implants and overcome a planned secondary CurvaFix implant within the same bony corridor. So looking at the top left image, we'll see that exchange tube that's radiopaque, where you have to take the ball tip out and put the smooth wire in just to demonstrate how that would look under x-ray. And then after that anterior column screw is in, we can start a standard LC2 corridor and use that wire where you can see in the top right on the obturator inlet and then on the iliac oblique in the bottom left and center image, how that wire can steer past up and over that anterior column implant without really any problem. And then you can see on that obturator outlet view where you're looking really up the pike, really that TP view in the bottom right, the implant kind of driving right up the sciatic buttress into the posterior superior iliac spine. Now, for this particular case, I wanted an additional augmentation of that posterior injury. And because she didn't have a complete fracture out the ilium and she was quite fragile and frail, I didn't want to make any larger incisions and get into any major blood loss. I did a corridor that essentially extends similar to what Samir was talking about, start point on the gluteal pillar, and extended into the posterior superior iliac spine. So rather than taking down into the posterior column, you can actually drive this wire back into the posterior pelvis at the PSIS. And I drew the fracture line there so you could see in the top right image how we can get two implants past the fracture line. And in the center top image, just to know that because the driving end is a little bulky, especially on the 9.5 implants, you can have a countersink that drives into the iliac crest along the gluteal pillar. And you'll just see some representative images of what this looks like, first with the actual insertion trocar, finally by the exchange tube getting down into the PSIS, and then followed by the final implant. So this is what the construct looks like for this particular patient with 3 CurvaFix implants tackling each additional injury. The anterior column was relatively non-displaced, so staying within the boundaries of the anterior column in an antegrade fashion is quite simple with this. That posterior, more difficult, I think, fracture was able to be crossed in 2 planes by 2 rigid, bent, fixed implants, which really imparts significant stability to the injury. And I will say the challenge in fragility fractures with this or any implant, to be honest, is really the imaging and making sure that you take time to get good quality images so that you don't drive that wire out into a place you're not intending it to be. It can be really challenging to get good images, but I would just implore you to take some time and make sure you can see what you need to see and be confident in what you're doing. And finally, just some post-op images. I made this patient immediately weight bearing as tolerated. They were able to ambulate with a walker almost right away. That was their baseline ambulatory status, was just with a walker. So she was able to get back to that within the first 2 weeks and stayed that way up to the 8-month mark, which was my last follow-up with her, and just showing these representative images here. So we'll save some questions for the end. I just want to turn it over to Nick Crescetti for the parasymphyseal fragility fracture portion.
All right, cool. Thanks a lot. Thanks a lot, Rob. So we're going to talk about parasymphyseal fragility fractures. If I can get this to work, I'm just trying to click into the system here, and there we go. So the objectives of this talk is pretty simple, pretty cut and dry. Just want to really give one clear message. The problem with parasymphyseal bone and fragility fractures of the pelvis, what will be abbreviated FFP henceforth, is to understand why that parasymphyseal bone is a problem. It's tough to fix, it's tough to manage, especially in these older patients with low energy pelvic fractures. We're going to talk about some potential solutions. The biggest thing is you really have to provide a strut against the internal rotation mechanism for the hemipelvis. And then we'll talk about just future progression at the end real quick. So let's start off with, this is an image that you don't want to have in your 2-week post-op follow-up visit. As you can see, this is an older patient that sustained a ground level fall. She had an internal rotation type injury to her right hemipelvis, where she had parasymphyseal fracture on that right side. And then she had right-sided sacral ala fracture as well. But this is the image that we want to avoid, where the entire anterior fixation with your standard retrograde screw has completely pulled out, and that whole right hemipelvis, despite the fixation in the back, has internally rotated, and it ended up healing in this way. But this is the 2-week post-op x-ray. So this is that same patient. These are the intra-op shots demonstrating appropriate starting point and trajectory for the retrograde superior pubic ramus fixation. That's a 6.5 millimeter cannulated screw, and good starting point. Inlet and obturator outlet demonstrate good placement. Here's the CT scan. I get a post-op CT on all my pelvises and acetabulums. And you can clearly see here, as we go from top left all the way to bottom right, that screw is in the parasymphyseal bone. Yet it's still pulled out. And this is what we end up with. So when you think about the anterior pelvis, I always think about it in the zones as described by Starr and Nakatani in their paper from 2008. You have zones 1, 2, and 3 of that anterior pelvic ring. Zone 1 is that parasymphyseal bone. This is everything medial to the obturator foramen. Then you have zone 2, which is the ramus that overlies the obturator foramen. And zone 3 is everything lateral to that obturator foramen. So the biggest issue is when you have fractures in zone 1 and zone 2. Zone 1, because the fracture occurs in the zone of really poor bone and narrow corridor. Zone 2 is a problem because you have to anchor or end your fixation in zone 1. Whereas the zone 3 fracture, you can have your fixation whether you go retrograde or antegrade, you will get stable purchase in zone 2. And that's what we're talking about here. Zone 1 and zone 2 are the problem. So whether you go retrograde or antegrade with your fixation, if the fracture is in zone 1, you're starting or ending in poor bone. It's poor bone because the patient's elderly. It's poor bone because it's mostly all cancellous bone. You have a very thin cortex, and it's a narrow corridor to start or end your fixation in. And like I said earlier, even if you have that fracture in zone 2 and you have completely intact zone 1 bone, it's still poor bone to end or start your fixation in when you don't have a stable corridor next to the fracture. And again, this is all assuming you have appropriate posterior fixation, because if you don't, you're making your anterior fixation, you're really putting it at a disadvantage. So solutions, like I said, zone 3 fractures, you're going to have good bone in zone 2 for your retrograde or antegrade fixation. So even if you start or end in zone 1, you're getting stable bone in zone 2 for a zone 3 fracture, if that makes sense. But the zone 1 and zone 2 fractures, those are the trouble. Those are the problem child, because you have to bypass zone 1, that parasymphyseal bone. You really need to bypass it because you need to get stable fixation on both sides of that fracture, medial and lateral. So how do you do this? If you go with a retrograde screw, your only fixation medial to that fracture is in zone 1. Poor, narrow bone. There's even likely some comminution there. That's the bone we're talking about. You can even try to cross the symphysis with the screw, but still you're in zone 1 symphysis and then zone 1 again. So you're still in poor bone, starting your fixation in poor bone. If you go antegrade, you're ending in poor bone. So there's no good stable fixation medial to that fracture, whether you go antegrade or retrograde. And this is kind of how we've done this for many years now. What you really need to avoid ending or starting in that poor parasymphyseal bone is you need to anchor your fixation in the contralateral zone 2 or even zone 3. You need a strut against internal rotation. So CurvaFix allows us to achieve that. So here's another patient, a fragility fracture of the pelvis. You have internal rotation injury on the right side, and you even have contralateral parasymphyseal fracture. So you have comminuted bone through zones 2 and 1 on the ipsilateral side. And then you have fracture through zone 1 of the contralateral side. So you really can't end or start your fixation in that parasymphyseal bone. So the only stable bone you have here is the supraacetabular bone on the ipsilateral side above the dome. And then you don't have good stable bone for fixation until you get to the contralateral zone 2. Well, the CurvaFix allows us to achieve that by bypassing the comminution, bypassing both parasymphyseal zones, and bypassing your symphysis. I could talk for hours on the trials of getting the fixation across the symphysis, the technique in doing so, but I think that the technique of doing that is a little beyond the scope of this practice or the scope of this talk. I mean, we're trying to just, deliver a message and show some solutions. But this implant, and this is the 180 millimeter length implant, that's as long as they go at this time, but that still allows you to start on the outer table on the side of injury, go above the dome, cross the ipsilateral anterior fixation pathway, cross the symphysis, and anchor your fixation in the stable bone of the contralateral zone 2. So again, you're going from these two stable areas, bypassing all that fracture, bypassing the symphysis, and creating a stable environment. And with the stable fixation in the posterior pelvis, this patient's allowed the weight bearers tolerated right away. And we've done this a couple times now. Here's another example, going from the opposite side. You had a left-sided fracture through zone 1. There's comminution, poor bone. Bypass it, anchor that fixation in the contralateral zone 2. And here again, you can see we did the same thing. You're ending your fixation in that stable zone 2 of the contralateral hemipelvis. So the CurvaFix has really allowed us to expand how we treat pelvis fractures, especially in these fragility fractures of the pelvis, where that poor parasymphyseal bone is even more poor because they're osteopenic or osteoporotic. And a lot of these fractures are comminuted. So for the zone 1 and zone 2 fractures, this has really provided a way to bypass that parasymphyseal bone, provide good stable fixation, and allow these older patients to weight bear as tolerated right out the gate. So future progression of this, currently the implant, like I said, it only goes up to 180 millimeters at this time. There are 2 diameter options, 9.5 and 7.5. 7.5 is the one that I choose for the anterior fixation. But we could use, smaller diameter varieties would be beneficial. And then it would, we'll try to work on getting some biomechanical studies because, I've already had some feedback about where you're crossing a joint, the pubic symphysis, with an implant that hasn't been studied crossing that joint yet. But so far, initial results have been very promising. So I think there's a lot of opportunity for future study on transsymphyseal fixation with the CurvaFix implant. So, and next up, we have Dr. Carl Van Osten talking about high energy acetabular fractures and how they can be managed with the CurvaFix implant.
All right. Good evening, everybody. Thanks a lot, Nick. I'm going to have Katie advance the slides for me when we're ready. So we'll go ahead and talk about some acetabular fractures and some higher energy injuries. I'll say this up front. I've been using CurvaFix for several years now, and I think it's very, as has been discussed by our previous presenters, it's extremely useful in a variety of different injury patterns and circumstances and around the pelvis and acetabulum. I've trended more towards using it in fragility fractures recently, but it's extremely valuable as well for the bag of tools and tricks for treating acetabular fractures. So we'll advance to the next slide. Disclosures next. So this case, first case I'll present, this was a 24-year-old male who was involved in a motor vehicle accident. He also had a right femur injury, left olecranon, a right distal radius. Next. So just some injury films. He basically had a higher energy right acetabular fracture. It was a transverse posterior wall variety. You can see his femur fracture there that was treated the day of injury with some early total care. Next. So this is the classic pre-reduction CT obtained by the emergency room physicians, which just shows some of the pattern of the injury there, the transverse posterior wall nature of the injury. The last slide on the right shows after we've treated his femoral fracture with nailing, and he's reduced in some traction for later definitive care of his acetabular fracture. Next. So I think we've had already some really excellent slides showing the versatility and the usefulness of this CurvaFix implant. And traditionally, the traditional fixation pathways, I think Samir did a good job of talking about posterior column. We all know about the anterior column, how you basically have to be really sort of, straight on with a good, perfect trajectory if you're going to try to use a straight implant. And that's kind of been the historic implant that's been used in these circumstances. But for all the reasons previously discussed, this CurvaFix implant is really, I think, performs very well in these circumstances. I think one thing I would like to mention is it's almost really beneficial to have sort of an off-axis start point, if you will. The forgiveness for the start point is, I think, a little greater, and what that does is actually allows your implant to curve even more, and you end up with this fixed curve And we talked about the bent axle and removing a broken or a bent femoral nail. And, you really have that additional fixation, the more curves you can induce into that implant itself. So we see some shots here with a starting point, an angle jaw clamp on the anterior column component of this transverse fracture. So we have the starting guide wire, then you use the opening reamer for this system. There's the metal guide tube that's inserted that sort of stabilizes your guide wire as you can snake it across, and it's got that curved tip that you can turn. It's been discussed by our presenters. You can direct it with little tiny taps as you change views, and you can get it all the way over to the symphysis. One thing I would like to note in this particular circumstance is a lot of people have asked me previously if you can generate compression with this implant, and I've been able to do that several times. I think was a little technically difficult with some of the original versions of the instrumentation, but I would try to basically tap that guide wire out and to get to a point where I could ream, as I think you can see in that bottom fluoro. I would try to get it out so I could basically end my implant with the threads in some potential cortical bone there to generate some sort of compression. And it's been successful when you can do that. I think with some of the advancements in the instrumentation like drill tip guide wires, that'll be even easier to do. So this was an earlier on case, and so that's actually the 9.5 implant. So the bigger version going in. Next slide. So you can see there kind of going into its final position, and I think you'd see in the fluoro that the threads sort of, if you can get the length just right, you can generate some compression as those, big aggressive threads sort of grab into some of the cortical bone near the symphysis. Next slide. So after going ahead and repairing the posterior injury, stabilizing the posterior column, and then repairing the posterior wall, this is what we sort of have with our final fluoro shots, and it shows a nice curve on that implant. Nice stability. It's I think extremely useful, even in the higher energy acetabular fractures. If you're not, obviously this is not a pure, percutaneous case. In this example, you're open, you're putting a clamp on, your displaced components of your fractures to reduce them, but this can still be used in this circumstance to stabilize such an injury with good results, and I think excellent stability. Next. So these were post-op images for this case. I think it shows, a nice example of that anterior column screw. Again, that's the bigger one. Nowadays, I'll use the 7.5 variant as Nick was talking about. Next. So here's this patient ended up getting a post-op CT for other reasons, but that shows some of the positions of the screw. Next. And this guy actually had 2-year follow-up. Just recently, he was doing very well and had a little bit of HO, but was back doing everything he wanted to do with no complaints, and sort of a successful outcome from one of the first cases that I treated high energy acetabular fracture with one of the CurvaFix implants. Next. So this is just a quick case too. This was a 25-year-old male, motor vehicle accident, no other injuries. Next. So he basically had this. It's similar to some of the stuff that Samir was talking about at the beginning of the evening, but basically this was sort of a non-displaced to minimally displaced transverse acetabular fracture. This guy was a larger guy. He was basically really aggressive about wanting to get back to everything he wanted to do, get back to work, et cetera, as was mentioned earlier. In some of these patients, that's hard. They're hard to slow down. Next. So we had the discussion about non-operative treatment. Get through the whole thing. I told him maybe we could do a percutaneous fixation for something like this that would allow him to weight bear as tolerated immediately. And so that's what we went ahead and decided to do collectively. And this is similar to what Samir presented, but I elected to go ahead and do antegrade posterior column fixation. And he had some really nice slides that showed, sort of the sequence of that. But this again, with the starting guide wire, the opening reamer, the guide stiffen it, the stiff metal guide tube that helps direct your wire, and then that curved, ball tip wire as it's, snakes around the acetabulum. Next. So again, just some good views of directing that all the way down, and then reaming. One thing I'll say that's nice that I've noticed with use of this implant is that when you actually go ahead and ream over that ball tip guide wire, it is nice. You're confirming that you're in a safe intraosseous pathway. I mean, you know it if your technique is good and you have good imaging. But it's always sort of to me, it's sort of satisfactory to have that feel of the reamer as it traverses down that osseous pathway, and you can basically get the chatter like you're reaming for an intramedullary nail. Next. So here, this is the 9.5 implant going in. After that is seated down across the fracture and locked into position to stiffen it. We went ahead and placed our anterior column screw. After that, you can see the fluoros on the right. Next. So this is kind of the final position with these two screws locked into place, nicely curved, I think providing excellent stability. And I was going to go ahead and let this guy immediately weight bear on this. Next. So there's some of his post-op images. I think an interesting way of doing that with down the gluteal pillar. I've had some good success with that. And one thing I mentioned, in these bigger patients, it's certainly easier. You can have pretty good access to the crest right there. It's very easy to get back to if there was some sort of issue and you needed to remove the implant. It's much more accessible than trying to do that retrograde, in my opinion. Go ahead, next. And so this is the last follow-up I had with this gentleman. He was doing really well at 8 months. He had no complaints and was back doing everything he wanted to do, back to work. So I think just two examples of some treatment of acetabular fractures in some younger patients, some higher energy injuries with this CurvaFix implant. And I would echo everything that's been said previously, about the curve, locking it into position. I think there's a lot of future potential for an implant like this. And we've seen some really interesting things, people pushing it, to treat, injuries that don't have good solutions. And also fragility fractures. I think this will play a large role in the treatment of fragility fractures in the future. So I think with that, it's probably time to take some questions for the group.
Well, thank you for that. Those presentations were great. Really, as we're sort of working through these surgeries and techniques, I see people doing some tremendous work with these implants and being very creative to all the presenters and some of the cases they showed. I sort of think back to how I would have treated them and now what I'm either doing or trying to do. I think a few questions have come up, and Paul, you touched on this as well. Are you using CurvaFix to get compression routinely for fractures that need either a little bit of a compression or an SI joint disruption that needs to be squeezed?
So
Nick? Oh, go ahead. Call you first.
Oh, sorry. I was going to say, so I've been trying. I really have. And I think, one of the things is obviously, with the original instrumentation, trying to get that ball tip guide wire just so and not kink it. I've certainly kinked a number of them, but just that subtle technique. And I think it also, the bone quality that you're dealing with plays a big role. I mean, in some really, some softer, more osteoporotic bone, it's a little easier for me to get it across. I've certainly been able to get, say, in an S1 all the way across, across the contralateral SI joints and out the table, all the way out the outer table. And then I think the second thing is because of the threads are at the tip and sort of limited, length, you basically sort of have to get lucky, I guess, where your threads are kind of ending, right just so as you're generating some compression, they're not, either too far out and losing that compression. So I have been able to do it. I wouldn't say it's sort of like reliable thing that I'm able to do every single time.
Nick or Rob?
If it's something that need compression, like in a sacral fracture or particularly an SI joint, or sometimes we get a little bit of a windswept pelvis where you're trying to get sacral fixation on one and you have a contralateral SI. I will go screw fixation first, followed by the CurvaFix, because the derotation effect you get from a CurvaFix when you put it in curved, I think is extremely beneficial. Now I say it that way because yes, in a dysmorph S1, you've got to take that big arc to get over and clear the dysmorphic segment. But even in a big, wide S1 segment, you could drive a semi truck through, you still get an added benefit from putting it in where it is curved in multiple planes. So that is one thing I think that is a little bit on the learning curve side of things. You're not using traditional start points, which is so unusual because, as you know, trauma surgeons, we focus on trying to make sure we stay within bony corridors. And there's no way if I take this wire all the way across, you're going to stay in bone. You almost have to dispel that and start way low, way posterior, and just have that ball tip wire deflect and move throughout the corridor. It doesn't have to be perfect. In fact, that's the crazy part. You want it to look kind of wonky and weird. Like you want the wire just to kind of dance through the corridor and take it all the way across. And then you get that bent axle effect. And sometimes, to Carl's point, if you get to the far side of the SI joint and you know you need to cross it, like sometimes you can just do a long kind of transsacral screw and stop just shy of the joint. But if you can't get the ball tip across it, this is something you want to probably prep the contralateral side in to make sure you can do another little start point and just put a guide wire and punch through the joint and make a hole so you get through the cortical part that's small, and you can just send the guide wire across and the screws will thread across it. The threads will actually bite into it. I've done that a couple of times, but I mean, it's something that compression is not super reliable. So I definitely am going screw first, followed by the CurvaFix second.
And I would echo that. I would echo that too. I'll you know, if you need to generate significant compression, I'll rely on something like an osteocentric or something like that. And then, you know, the CurvaFix is nice to sort of lock in everything. But, you know, I certainly have played with the ability of that screw to compress. I do think with the new instrumentation that's coming out with the drill tip ball guide wire, that it does make it easier to cross certain areas if you need to get across.
Nick,
Yeah.
there's a lot of questions about weight bearing. So I'm going to put this on you because you seem to do a lot of fragility fractures. Are you immediate weight bearing all these patients post-operatively that you're putting a CurvaFix in?
All of them. All of the fragility fractures of the pelvis I treat, they're all weight bearing is tolerated day one. No matter, I mean, really, no matter the fracture pattern. I'm of the school where, you know, if you have an injury in the posterior pelvis, I'm going to put as much fixation back there as I can fit. So I'm getting kind of tying in the previous question, I'm putting in a cannulated screw at S2 to try to gain some compression there, especially if it's a zone 2 fracture or zone 2 type pattern in the back. I think if you use the 9.5 or the 9.5 millimeter, because the head is shaped, so the head on the 7.5 is self-drilling, self-tapping. So that'll continue to pass, whereas the head on the 9.5 doesn't. So I think you can get some compression effect with the 9.5 a little better. But even still, I'm you know, filling up the back of the pelvis, and then I'll put the fixation in the front. And I do feel a lot more confident letting them weight bear as tolerated with the transsymphyseal CurvaFix.
In the last couple of minutes we have, because I do want to be respectful of everybody's time and thank everyone for being on this webinar. And before people start to step off, I want to thank CurvaFix for sponsoring this in conjunction with the Orthopedic Trauma Association. So appreciate the OTA's time as well as CurvaFix continued support of the OTA. I have to ask, because obviously these are priced differently than traditional cannulated screws, how have each of you been able to get a product like this into your hospitals through your value analysis committees or your new product committees? And what's the rationale that you've used? Because I think that could be a challenge for some people. So we'll start with Rob, Nick, and then go to Carl.
So listen, I've fought some battles with my supply chain, and I kind of have to say this wasn't one of them. I'm super surprised that it wasn't. I think that the fact that there is just nothing like it in terms of the differentiating nature of it being curved and flexible, it doesn't it it didn't even really come across as a comparison to a screw. It was just like in its own league, which like I've had, like you mentioned, osteocentric, like we've tried to get those in the hospital. That was a problem. I mean, different updated versions of nails, whatever. It's always an issue. I didn't have that with CurvaFix, and that's not even an embellishment. We were able to get this through as something very unique, and particularly because I think only our trauma surgeons were really using it, the ones that were treating pelvis fractures. So system wide, it wasn't a tremendous burden from a financial standpoint, but I didn't have a big problem. I maybe one of the few battles it wasn't a challenge with supply chain. It's just so there's nothing else like it, so it doesn't really compare to a screw.
Okay, Nick.
Yeah, I kind of agree with Rob. I mean, my facility, I'm at a level 1 trauma center, and they like to make sure that if they're going to spend money, it's for a good reason. So the value analysis committee is pretty tough to get anything passed. But this was different because it provides something that's not available on the market, and it expands your ability to percutaneously treat patients. Whether it's a trauma patient who you don't want to keep in the OR for a long time, or an elderly patient that you want to get in and get out. So it allows you to take some procedures that may have been more open and make them all percutaneous, decreases time in the OR, time in the anesthesia, decreases blood loss, and it expands your percutaneous repertoire. And it's something unique and novel on the market that doesn't exist. So for those reasons, it was pretty easy.
Great. And Carl.
I would echo all of that. I mean, it was really not a battle for me at all, either. This wasn't like you're trying to, get them to bring in the third different type of femoral nail or something like that. This was, clearly a situation where this was a unique implant that it could expand, not only sort of potentially, treat these injuries in a more, expedient fashion, percutaneously mobilizing patients up out of bed, getting them out of the hospital. But I also kind of, discussed with them, we run a fragility fracture program here as well. So we sort of discussed the expanded indications, like we talked about at the beginning about, how these pelvic fragility fractures may sort of go the way of hip fractures and be operated on more and more, with the types of population that we're seeing. So, that sort of ability to treat those injuries was also sort of attractive to the hospital as far as getting some business in the OR.
Great. As we close out, I'll again give the floor to each of you. Any parting thoughts or comments to the audience? If you had to sort of summarize your experience so far, or things that you want to make sure they leave with tonight. So we'll go in backwards order this time. We'll do Carl, Nick, and then Rob.
Sure. Thanks everybody for watching. I think that the most interesting thing for me, and we've touched on it a few times, but as traumatologists, we're so trained to to think about these perfect starting points and these long linear trajectories, and trying to get the best fixation we can. I think the really interesting thing for me has been to play with this implant, which is truly unique and different. And I've started to really exaggerate my starting points in the sort of the quote unquote wrong spot, to purposefully get this implant to curve as much as possible, and explore the various options for that. So I think it's really a great implant, expands the toolbox and the kit for the treatment of complex injuries. And I think it's quite interesting.
Nick?
Yeah, no, I think it's great. And if you are out there and you're watching this and you're thinking about trying it, before you do it in an operating room setting on a patient, definitely get it in a lab. Use it on a skull bones, because there's definitely a couple cases, a learning curve. So get your hands on it, use it, in a cadaver, use it in some saw bones before you try it out, but definitely get your hands on it. Strongly recommend it.
Rob?
Yeah, I think one thing that I kind of glossed through in my first presentation too is that because you have these atypical start points and because you have these trajectories that you're not used to, you can really kind of consolidate where you start to think about tackling fractures from. Meaning, if a corridor looks better for a certain pattern, if you were thinking for a screw to go antegrade or better retrograde, you can go either way with a CurvaFix because you can cannulate that unusually curved pathway. So once you get a little more facile with it, you can start to really think out of the box and like apply. Like I never thought I would be able to do gluteal pillar to PSIS. Like there's so many pathways within the pelvis that if you just kind of get that rigid linear pathway out of your mind, you can start to really fill up and apply an extreme amount of stability. But I guess the main message I would want to give to someone who's never tried it, who's curious, for the first time or two or three, just have a little bit of patience and work through it in a way that's kind of calm and planned. I know that sometimes in my own practice, there's 2 rooms and we're running things and it's crazy and you want to get done, and don't make that your first case. Like really think through this and enjoy something new that can really impact your practice in a positive way. And I think if you give it that chance the first couple times, your learning curve is going to be pretty shallow and you'll be able to start thinking quickly in a new and different way that you didn't think about pelvis fractures before. That's what happened to me.
Gentlemen, thank you for your time this evening. I want to thank all the participants in the webinar. I think all the questions in the chat room have been answered and on display for all the group. So really appreciate the participants being here. Really want to shout out to the Orthopedic Trauma Association for doing something like this, and a shout out to CurvaFix for helping sponsor this particular session on pelvic and acetabular fractures, which I know is what separates us from everybody else. So I like to think of it that way. Thanks again for your time. Enjoy your evenings and have a wonderful summer. Hopefully we'll see some of you using more of this tool. Take care, guys.